Hi everyone, and thank you very much, Liz, for the introductions and the invites. And I love talking about quality improvement, so that's what we're here to do today. A little bit about me. Unfortunately, I won't have the time in the next hour to get to know you as well as I would like. But my name's Catherine Strutton. I'm a consultant anaesthetist and intensive care doctor. I work in a kind of small district general hospital up in Scotland. So I'm talking to you from Edinburgh today, isn't it? The wonders of a Zoom world. We specialise in kind of max fax and burn surgery where I work. And very, very early on in my training, going back many, many years now, I got really interested about the idea that there were lots and lots of people who work in healthcare or in and around healthcare who are all trying really hard to make things better. But I noticed that effort seemed to be sporadic when people had the energy and time for it, lacking in joined up thinking, and it was often driven by the notion that people had like this extra energy and enthusiasm, or there were also pockets where people were just trying to improve their own CV rather than really improve the work themselves. And often all of that effort was done on the background of goodwill. So when I stumbled across quality improvement back in about 2005, I got really excited by the idea that there was actually a way to do this better. There was a way to kind of guide that improvement. And I'm hoping that I can instill in you guys some of the enthusiasm that I have for quality improvement. So during the last nearly 20 years, I've been trained by the Institute for Healthcare Improvement, who are a fantastic group that I would urge you to go and Google. The Royal College of Anaesthetists are involved in QI now, and I regularly deliver and support QI work across my own institution and also with MedLed. And we've done some amazing things. So we've reduced cardiac arrests in the hospital trust that I work in by 50% in 18 months, and that was using QI. We have improved staff morale and well-being in a measurable and repeatable and sustainable way using QI skills. I've also managed to make my husband make me a better cup of tea in the morning, so I'll share with you some more of that later on. But QI, I can assure you, is the answer to solving problems where you work. So just a few bits of housekeeping here. We've just got an hour, so this is unfortunately going to be a bit of a whistle-stop tour, and I'm hopeful that it won't be too much information too quickly. But with the recording, maybe if it's all coming a bit thick and fast, you might have the opportunity to come back to it later. Feel free to ask questions in the chat function. Liz has very kindly said that she'll collate those together, and we'll leave some time at the end for that. And I'm going to share some examples of work that I've been involved in, and I appreciate if that work was kind of kept confidential and not chatted about in the pub at a later date, just in terms of those people who've been involved with that. And this is what I've been asked to talk about. So a bit about what is quality improvement for those of you that maybe are new to the terminology. A bit of understanding of how the science works. It's not just doing stuff. It's a scientific, validated, proven methodology that if you use well, will stand you in good stead. We're going to talk about some tools and techniques. So hopefully you've got something to take away that's really, really useful. And one of the key things I think to try and cover today is how you get buy-in, especially in the world that we're in at the moment. Everybody is a bit burnt out and struggling with work, and there are pockets where things are better and things are worse. But I think if we can find a way to really get teams enthusiastic and engaged in quality improvement work, all the more successful for everybody along the way. And what I plan to do is take these objectives kind of in tandem as we go. And so hopefully there'll be lots of useful tips and tricks for you to take away. So the science of quality improvement has actually been around for a very, very long time. And whilst I am more than happy to delve into Walter Schuert's 1940s PDSA cycles, there's actually a chap called Don Bowick who does it pretty well in just a few minutes. So there's a video here for you to watch. I have checked, hopefully the technology will work well for you, but if anybody's having any trouble, just pop it in the chat function and we'll get things sorted. It should be starting in just the next few seconds.
I'm Dr. Mike Evans, and today's talk is on quality improvement, or QI, in healthcare. So I suppose the first question is, why should you or I care about quality improvement? I mean, to be honest, it sounds a bit boring. A CEO would have on her or his corporate objectives. But actually, if you dig a little deeper, it's pretty cool. You get more of a philosophy or an attitude about how to make something better. And now that I think about it, it's really the attitude I'm looking for in my patients. the ability and desire to tweak their habits, seeing if this change improves their life, and if it does, to try and make it standard practice. You see, for my patients to make these changes requires skills, but it's also an outlook, the humility and self-awareness to say, I've got room for improvement, the ability to gather better approaches, try them on and see if they work, and then adapt them until they do. Well, if my patients can do that, I think they deserve the same from us in the healthcare business. So I suppose the next question is, if we have the attitude, how do we actually improve? How do we use QI to make care better? Well, the improvement business has been around for a while. Organizations like Toyota and Bell Labs and leaders like Walter Sheward, W. Edwards Deming, and Joseph Juran polished and simplified the science of improvement. And then along came a pediatrician named Don Berwick, and he wondered if we could translate the science of building better cars or electronics to healthcare. Dr. Berwick also wondered if there were lessons about systems we could learn from the kids he saw in his clinic.
The systems thinker is a perpetually curious person who never thinks they have the whole answer, but is always willing to know what the next step to take is. If you watch a child, you'll see this happen. Children in their growth and development are innately systems thinkers. They're always trying the next thing. They're probing the material. They're listening to the noise. They're thinking about what the next thing to do is, and they're not in the job of solving problems forever. They're in the job of taking the next step. I think those are elements of what it means to be a system thinker. At the core of it is constant curiosity about a world that you will never understand fully, but you might take the next step to understand a little better.
Okay, we've never dropped a vid into our vids, and Don is thoughtful, so I kind of thought it might improve our messaging. Let me know if you thought it did or didn't in our YouTube comments. Now, Dr. Berwick went on to co-found the Institute for Healthcare Improvement, or the IHI, and started focusing on the low-hanging healthcare improvement fruit, which is mostly reducing errors. For example, in Canada, a researcher named Ross Baker led a study in 2004 that showed of 2.5 million annual hospital admissions, about 13.5% were having adverse events, with 1 in 5 of those people dying or experiencing a permanent disability. In the US, the Institute of Medicine estimated that 44,000 to 98,000 people were dying from preventable errors every year. That's up to 4 jumbo jet crashes per week. Often these are errors we know how to prevent, but as is often the case, knowing what's the right thing to do and actually doing it are 2 different things. In 2006, Berwick and his colleagues challenged hundreds of US hospitals to bridge this gap and felt strongly that some is not a number and soon is not a time, and so set the goal of saving 100,000 lives in 18 months. They started with this simple notion: every system is perfectly designed to get the results it gets. So how do you change the result? Well, you change the system that produces it. Changing the system requires change agents, and in my province, we launched Health Quality Ontario. HQO and orgs like it recognize that it's tough to balance proactive and reactive care in the field. But if they can help or incentivize or nudge us towards a more reflective practice and improve outcomes, we can actually create a better user experience for us all. Now, making this sound simple, like pushing a button, but getting people to change, even a simple behavior like hand washing, can be very complex and exasperating. But these seemingly small behaviors can have a ripple effect on health. A 2010 study calculated inadequate hand washing caused 247 deaths each day from preventable hospital infections, and that's just in the US. So let's jump back to simplicity. How to improve seems to boil down to 3 questions in a cycle. Improvement starts by setting an aim. So question number 1 is, what are you going to improve and by how much? So for example, we are going to get 70% of the staff to wash their hands before and after seeing patients by December 1st. Great. We have an aim. So let's start testing some changes, okay? Not so fast. Now you need to ask question 2. How will you know if a change is an improvement? We need to choose some things and measure them. What is doable and reliable? And that will tell us if the changes we are making are leading to an improvement. Is someone documenting doctor or nurse hand washing? Is it self-report? Is it the amount of soap and disinfectant used? Okay, we have an aim, and now we have some measures. Next up is question 3. What changes can you make that will lead to the improvement? To start, we just want to test one change with something called a PDSA cycle. Plan the test, do the test, study the test results, and then act based on those results. Maybe it's new soap dispensers or little bottles of gel. Maybe you read about the study that changed the signage from wash your hands to protect yourself to wash your hands to protect your patients, which resulted in a third improvement over a 2-week period. Maybe it's reward or audit and feedback or asking patients to check. Just pick one and get started. Then you test other changes and the PDSAs just keep rolling. Fine tuning the change based on what you're learning. Saying to yourself, here are some ways we can improve. Let's try them out by dropping them into our practice in a thoughtful way that fits with our clinic and our patients. And let's measure how we do. Adapt, adopt, or discard. Simple, right? But powerful, and it actually works. At my hospital, St. Michael's in Toronto, elderly patients with fractured hips were often waiting more than 2 days for surgery. This wait was painful, with increased chances of conditions like delirium and depression, longer recovery times, and even death. The care team scratched their chins, mapped out and redesigned every step of the journey to surgery in order to fast track these patients. They created a code HIP called as soon as the patient arrives. This streamlined them to the urgent list for surgery, rapid triage, essential testing, priority consults from anesthesia and internal medicine, and so on. All these tweaks led to a jump from 66 to over 90% having surgery within 48 hours. The main point is start. Find something you can improve and get going. Look, it's hard to summarize improvement and not get into bumper sticker territory, but I would advise not to let what you can't do stop you from what you can do. It's time to entertain complexity, but focus on simplicity. Asking yourself, what can I do by next Tuesday? Have a meaningful needle and test some changes to start moving that needle towards an important goal. Hope this helps, and thanks.
So that's a bit of a whistle-stop tour there through quality improvement, and what it boils down to is 3 questions and then some PDSA cycles. So the science is simple and it is easy to use. And what we're going to do is we're going to take each of these elements, and hopefully I'm going to give you some tools as to how you can drive these forward, and then also ways in which that you can try and improve engagement in each of these steps and make your improvement work in your own working areas as effective and as straightforward as possible. So the first question in our model for improvement is this one. So what are you going to improve and by how much? And I think that before you go anywhere in terms of starting any improvement work, it's really vital to spend some time getting this right, because otherwise what happens is you spend a lot of energy and resource trying to drive things in the wrong direction or towards the wrong place, and you use up all of that energy and buy-in that you've managed to create in your team. And one of the ways that we use to help us try and make sure that our aim and our starting question is as useful to us as possible throughout our improvement work is to use this acronym, so SMART. And some people in the room may well have come across this before. So SMART is an acronym that helps us understand when we're setting that initial statement of what we're going to improve and by how much, to get us as kind of as clear as possible in our minds what we're trying to achieve. So SMART stands for specific, measurable. It's got to be achievable, because otherwise everybody just gets disheartened, and that's the last thing we want to do with our staff working in the way that we're working at the moment. It's got to be relevant to our work, and we need a time phase as well. So what does that actually look like in real life? Well, I was involved in an improvement project just fairly recently, and the improvement work aim was to try and give our patients better care. But actually, that's not a very specific, measurable, accurate, time-phased, achievable, relevant statement. So we tried to improve it, and what we wanted to do was to reduce the number of cardiac arrests in hospital. And we knew that we had a problem with those up in the trust where I work up in Edinburgh. And then we thought maybe actually just in hospital is a bit vague. So maybe actually we should be looking at cardiac arrests that happen in the hospital ward. So not in our critical care units, not in our emergency department, but on the hospital ward. So that's a little bit more specific. We're moving in the right direction. And then we noticed that we didn't have a by how much statement. So we thought we could reduce the number of cardiac arrests on hospital wards by about 50%. And then we needed a time phase for it. So this became our aim statement. So we were going to try and reduce the number of cardiac arrests by 50% in the course of the next 18 months. And our SMART aim was constructed after we had done a huge amount of work. And this is my first key takeaway for everybody who's with us today, is you can't set an aim, you can't even begin to answer the first question of your quality improvement methodology until you understand the difference between this. So work is done and work is imagined is terminology that was first created by a guy called Steve Shorrock. I'm proud to say he's worked for a lot of his career in Scotland. And Steve Shorrock talked about the idea that in any attempt to understand or intervene in someone's work, there are several types of work that you can consider, but that in practically all attempts to understand and intervene, we're not actually really considering the purposeful activity of work. That's work as done. And rather, what we do is we use proxies for work as done as the basis for understanding what's happening and how we might intervene to improve that. And work as imagined is one of those. Work as imagined is what we think is taking place. And have any of you guys been in a situation where you've been told to change something or do something faster or be more efficient or change the way you're working, and the person who's given you that instruction has so clearly got no idea of what that work actually looks like on the shop floor? Well, this is exactly what Steve Shorrock's talking about. There is no point us creating a SMART aim to reduce cardiac arrest in hospital by 50% in the next 18 months if we just imagine that that's something that we're going to be able to do. We need to really do a lot of background work before we start to understand work as done. What is actually happening in this process or in this part of my system before I can even consider where there might be or how there might be room for improvement. And this comes back to a great statement in that video that we just watched. So every single system in the world is perfectly designed to get to the results that it gets. So if we want to change the system, we have to understand work as it is actually done in order to change the right part of that system to change the outcome for most people coming through. Now, one of the ways of getting that buy-in and that engagement with our teams is to really show them the effort that we're going to understand work as done. And there is a fantastic tool in quality improvement science called process mapping. So a process map is a visual display of where a process starts and where it ends, with a sequence of steps in between the start of the process and the end of the process. And those steps occur in the order in which they happen in real life. There are usually arrows that delineate choices that are made or decision points that occur within that process, and then arrows that connect the steps in the process in the order in which they happen. And then there are some other pieces of information that is really helpful in process maps. So the shape of the boxes that we draw is important. Rectangles or squares are just steps in the process that require no thought or consideration or expertise. So that's something that every single person would do when they reach that point in the process of that bit of work. And you can't really deviate from that step, or you shouldn't be able to. And then we also have diamond boxes. So diamond boxes denote when there's a choice involved, and that's usually a kind of digital response, so a yes/no option. So I got very, very sick and tired of my husband making me terrible cups of tea in the morning. So I came up with this. This is Kath's process map for making a cup of tea. Now, I think most of us, if I asked anybody in the room before I've shown you this process map, the process of making a cup of tea, I think most people would describe a 5 or 6 step system that went something along the lines of fill the kettle, boil the kettle, put a tea bag in a mug, put the water in, put the milk in, and deliver it, ideally to the person who's having a nice 5-minute lie-in in bed before the day starts. But you can see here, when you actually boil down to it, a process even as simple as making a cup of tea is a bit more complicated. I don't know if whilst you've been talking, you've had a chance to work your way through your perfect cup of tea on my process map, but I showed this to my husband very, very proudly, you know, with instructions that this was going to improve his quality of tea making every morning. And then he said, the immortal words in the Stretton household, what about sugar? So my husband takes two sugars in his tea and I don't. And you can see that in my world, in my worker's imagined world, what making a cup of tea looks like, there is no need to include sugar in the process. But in Paul's world, that's very important. So even this slightly complicated looking process map for making a cup of tea is considerably less complicated than it needs to be, because what about fruit tea? What about sugar? What if you actually want an iced tea? There are so many different routes that we could go down. There's a really interesting gentleman who works in Wisconsin in the States who I've had the pleasure of meeting once or twice, a chap called Matt Scanlon. He is an intensive care doctor and he works in Children's Hospital. So one of the most stressful environments I could consider anybody choosing to work. And he's really interested in the notion of work as imagined and work as done. And he looked at a simple process in his intensive care unit, which was the process of giving a patient in his intensive care unit a medication. So once that medication was prescribed by one of the members of medical or nursing staff, the process of then the nurse getting that drug to the patient. And again, if I sit here thinking about my work in intensive care, I would imagine that to be a fairly simple 5 or 6 step process whereby the nurse reads the prescription and she goes to get the drug from the cupboard, and then she brings that back to the bed space and dilutes it or crushes it or gets it ready to be delivered to the patient, and then injects that in intravenously or delivers it down an NG tube or orally or whatever the appropriate route of administration is for the patient. And what Matt Scanlon found was that he started following nurses around and writing the process maps, and not a single one of them was the same. And then he got 4 PhD students to come into his ICU for 2 weeks and follow all of the nurses round and write down the process of them giving the drug to the patient. And they came up with 400 different process maps, more than 400 different process maps for the process of administering a drug to a patient in ICU. So it was things like, a nurse notices prescription has been written into the drug chart, goes to the cupboard to get the drug, and the drug isn't there, so then has to go through a complex pharmacy order system to get the drug. Or nurse manages to get the drug from the cupboard and is walking back to the patient, and then is told to go for a tea break by the nurse in charge, or gets distracted by an emergency and 2 bed spaces down. Or you can imagine, I think, in all of your own places of work, how what a seemingly simple task can become unbelievably complicated in its process by virtue of the fact that actually what we imagine our work to look like and what it actually looks like in real life are 2 different things. So if we go back to tea making, if I wanted to improve my husband's tea making and I talked about just a 5-step process as my start point to try and change his system, I don't think it would have made any difference at all to the idea that my tea would get better, because the most important question for me is this one down at the bottom right of the question. Is the bottom of the mug clearly visible? I like a really strong cup of tea, and my first 5 steps would not have included that question in. So if we want to understand how to improve our system, this is a really important way of getting a true understanding of what it is that's actually going on at the moment, to give us an idea of ways in which we might try and improve it or might try and change it to change the outcome for the people that we're looking after. Process map. So then the second question we come to in our model for improvement is, how do you know if the change is an improvement? So this comes back to measuring things. And this is one of the things I really like about improvement work, is because the idea of measurement in quality improvement is very, very different from the idea of measurement if you're doing a piece of research or an audit, where often in those situations, you want huge volume of data to really prove beyond statistical significance, beyond any mathematical doubt, that an improvement is happening. And that's not the case. The data that we're looking for when we're doing improvement work is very different. And what we're trying to do is choose some things and measure them. And it's much more important that we choose to measure something that's doable and reliable and relatable than it is that we get lots and lots and lots and lots of quantity of data. And it's important, I suppose, that the measurements that we take is telling us if there is an improvement happening or if there is a change happening to the outcome of our process. So in quality improvement, we try and make our data collection reliable, repeatable, and ideally as real time and continuous as possible. And this is something that I've found in my experience, again, really helps to drive engagement with teams that are working in areas where improvement work is happening. I think when teams who are working hard and are wanting to see an improvement in their system, let's face it, most people who work in healthcare in one way or another are there because we want to make things better for the people that we're looking after. I think when the team starts to see a real-time change, especially a real-time improvement in their performance, in the quality of care that patients are seeing, that really helps to drive an ongoing effort towards the change that's being tested at that point in time. And I try always when we're doing quality improvement to present that data in as obvious a place as possible, obvious for the team to see, but also obvious for our patients and relatives to see as well. And there are different types of measures that we talk about when we talk about improvement work. So the first one is outcome measures. So these are things that the ultimate goal that we're trying to achieve. So going back to that example I've shared with you about reducing cardiac arrest by 50% in 18 months, that's our outcome goals are usually very, very closely related to our aim statement. So, and then our outcome measures can also be, they don't necessarily need to be about the patients themselves. They could also be actually about us and our experience as caregivers or healthcare providers or the community around us. So for if we took diabetic patients, our outcome measure of improving the care of diabetic patients might be the average blood sugar level for a population of patients with diabetes. For patients in hospital, it might be looking at reducing the number of adverse drug events per 1,000 drug doses that are administered. And then if you were in the community, potentially in a GP practice or a different, maybe potentially a hospice environment like Liz, it might be looking at the number of days to the next available appointment. It doesn't really matter what your outcome measure is, but that's the ultimate goal, the ultimate thing that you're trying to change. And then we have process measures. So process measures are the things that give us an idea that we're going in the right direction, because usually our outcome measures are really tricky to shift and they take a lot of work and a lot of continuous effort. So process measures are ways that we can get a sense that we're going in the right direction. So are the things that we're changing or trying to change actually happening, and are we on track in those efforts to amend the way that our system is working for our patients? So potentially, if we think about those examples I just talked about, the diabetic patients where our outcome measure is about looking at their average blood sugar levels for the whole population, potentially what we could do is look at whether patients with diabetes are having their blood sugars measured twice every year, or more frequently than that, whatever process you feel is going to contribute to improving that outcome measure. For the community example about number of days until the next available appointment, potentially your process measure might be the average number of hours per day or per week that was available for appointments to be made by clinicians. So our process measures, when we see our process measures starting to change and starting to improve, we would hope that then we would go on to see our outcome measures starting to be nudged in the right direction. And then something that's really important in terms of building engagement and enthusiasm for improvement work is balancing measures. So one of the things that I have fallen foul of many times in my career is my enthusiasm to drive forward a positive change in an area where I work and I'm really invested has actually made somebody else's life worse elsewhere in the system, and I didn't know about it. And because of that, what happened is the change I was trying to continue to drive forward ended up just fizzling out, and we lost engagement and enthusiasm for it, and the improvement was then lost. So balancing measures are vital. So the idea of balancing measures is it's all about looking at your system from a different angle. So if we're trying to, if our project is about trying to reduce the length of stay in a ward, what we might do as our balancing measure is looking at the readmission rate. So are we kicking our patients out really early? And that's brilliant. Our process measures and outcome measures are all going in the right direction. Well, that means nothing if those patients are just bouncing straight back into the hospital within 24 or 48 hours. If our project is looking at trying to improve one's husband's ability to make a cup of tea, then that's great. We can look at the outcome measure, the quality of the cup of tea that's produced, but our balancing measure might be the length of time that it takes for that cup of tea to appear, or the frequency of days of the week that the cup of tea does actually appear. And there are loads of different ways we can do this measurement. So it has to be achievable and it has to be as real time as possible. And ideally it should be very, very repeatable. So it happens with good reliability. So where I work in intensive care, there is a series of things that we try and do to reduce the chance of patients who are on ventilators getting chest infections. So we do things like we sit them slightly head up in the bed, so usually at about 30 degrees, and we try and clean their teeth every day and reduce the chance of any bugs that are in their mouth going down into their chest. And what I might do if I was trying to improve the outcome of patients having pneumonias when they're on ventilators is I might say once a week, every week, I'm going to see how many of the patients in my intensive care unit are properly following 3 of the 8 actions that we take to comply with ventilator-associated pneumonia prevention. And I would once a week go around the unit and collect that data and present that in a run chart, which we'll come to talk about later. Looking at adverse drug events, there's absolutely no way that anybody in the world has got enough time to go and look at a whole ward of drug charts and establish whether there have been any mistakes made on those drug charts, or a patient's been given the wrong dose or the wrong type or the wrong time of drug administration. So what we might do there is just look at 20 random drug charts on one day every month and look at that and whether there are any adverse drug events in those 20 drug charts, and divide that by the total number of drugs that we estimate to have been administered over that month-long period. And then if we were looking at flow through the emergency department, how long are patients having to wait to be seen at triage, and how long is it before they'll be discharged from the emergency department into the ward or discharged back home? We might look at 5 patients for 5 days in a week, but maybe include the weekend in that because the emergency department runs 7 days a week always. And we might just measure what is the time to discharge from the emergency department. So you can see with improvement work, we can choose a route of measuring our changes that is repeatable, that is reliable, that is real time, and that we can present to the whole team that are involved in trying to drive our improvement forward as a way of continuing to drive engagement and involvement in the process of improvement. So then this is coming on to how we show the data that we collect. And this is often where I find that people get most scared about quality improvement, because most people are a little bit scared of run charts. So run charts are a statistical tool. They're not just kind of a pretty graph. It's just as validated as all of the statistics you'll see in any piece of medical literature or any new drug that's produced and tested in a randomized control trial. But they're very, very, very simple things. And what they do is they help us to understand the data that we're measuring with our outcome process and balancing measures. And the key thing to always remember about a run chart is what it does is it differentiates between random and non-random information. So what we're trying to do is we're trying to understand whether the difference that we're seeing in our data is because of just we happen to measure it on a funny day where there was something in the water, or is it something that's changing because of the difference that we're making in our system, because of the impact, the test of change that we've brought into our process that's aiming to alter the outcome for our patients that we're looking after. So this is an example of a run chart. So you can see along the bottom there, we've got week number 1 to 26, and that's something that we're measuring every single week all the way through our improvement project. And then between on the y-axis there, we've got the compliance between 30 and 100. So it doesn't always need to go down to 0. And maybe the best example we can use to talk through this run chart, we'll be talking about the hand washing example that the IHI used in that video we watched together, or just at the start. So we've got here in week 1, week 2, week 3, we've got about between 55 or 50 and 60% of patients complying with washing their hands in the way that would be expected. And the improvement team here have collected at least 6 or 7 weeks of data before they've kind of formed their improvement team. And that's really important to know about run charts. So no matter what, when you're doing any improvement work, you need to get at least 6 data points before you try and change anything. Because if you change something and you don't have 6 data points before it, it's really hard to know if that thing you changed made any difference to the thing that you're measuring. And then you can see in about between weeks 9 and weeks 10, the improvement team here have started testing and adapting changes. And in week 13, they've implemented a change there. Perhaps that was that poster that they talked about around changing the sign from wash your hands to protect yourself across to wash your hands to protect your patients. And you can see that you can see a steady climb in improvement in compliance in hand washing, from hovering around that kind of 55% mark all the way up to hovering around 75 or 80%. That would suggest that there has been a change in our outcome measure, or if it's a process measure that we're measuring. The other thing to say about run charts is ideally you need about 25 data points in total to be able to be really sure that you're differentiating between random changes and non-random changes. Now, that's not 100% the case in healthcare, but it's a good rule of thumb to just try and live by. And then when we look at the run chart itself, there's several things that it can tell us. So the first thing we look for is a shift. So you can see there's a solid horizontal line there that's labeled the median at 68%. So every time we add a data point to our run chart, we should recalculate the median. So the median is a type of average. It's the middle number if you put all of the numbers in order, and it's used on the run charts to establish establish whether or not there's been a shift. So you can see from week 11 into week 12, the compliance with hand washing goes from about 52 or 53% up to about 70%. And then we see that the data crosses that median line and it hovers above the median line for more than 6 data points. If I just count, we got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We've got 11 data points there above the median line. So that's more than 6. So a shift in our data detects non-random. That is a non-random change in our data. Our data is telling us that we have made a change that has made a difference to what is happening in our system. So one of the other things that we look for that tells us that there's a change in our data is a trend. So a trend is when we see all data points either increasing or decreasing. So if we start here in week 11, we've got a move up to the median line in move 12, and we've got another move up above the median line in week 13, but then there's a drop down. So we've not got 5 data points going all in an increasing direction. And actually in this run chart that's shown, there are no examples of trends because there are no examples where there are 5 data points all climbing one on top of each other or all decreasing on one on top of each other. One of the other key features of run charts is if you have too few or too many runs. So a run is just a group of data points that are either above or below the median line. And as part of using a run chart, one of the ways in which you can check that your data is validated is by comparing the number of runs you have in however many data points you have, against some, I suppose they're statistical tables that have been constructed by mathematical statisticians. You just go into Google, you type in run chart, and it will ask for the number of data points that you've got. So in this chart, it would be how many weeks we have. So we've got 23 data points, and it will tell us how many runs we should have in our data. And if we have too few or too many, then we need to go back to our data to try and understand what's going on, because probably there is something in there that is impacting on what we're measuring that we're not aware of. And then the other thing that we always have to worry about with run charts is an astronomical data point. So this would be something like, so if we stick with our hand washing example, so very occasionally, and I would never name names, but very occasionally I will arrive on my intensive care unit first thing in the morning, ready to start my day, and the charge nurse whispers in my ear, "The infection control team are auditing us today. Make sure you wash your hands." And amazingly, what happens is every single person in the unit washes their hands perfectly that day, because we're aware that we're being watched. And all of a sudden, our run chart might be hovering along at about 70% compliance. And then we have a single day where we have 100% compliance, and the following day it goes back to 70%. So that data point on our run chart would really stick out like a sore thumb. We would know that there was something going on. And it's important that we go back to that data to try and understand what has changed in our process or in our system to cause that sudden change in the data. And usually what you would do is then just ignore that astronomical data point when you're calculating your median line in the future. So run charts, very, very simple to produce in Excel. If you put your data in 2 columns and press F11 on any non-Mac computer, the Excel will produce a run chart for you by magic. And it's fantastic if you can keep them updated every week or every couple of weeks, so the team on the shop floor can see what is happening with the changes that they're implementing. So we've made our way onto the very last question in our model for improvement. So what are the changes that you can make that can lead to an improvement? And there are loads and loads of tools that exist for ways to try and develop ideas of what might work. But importantly, whenever I get to this stage in improvement work, I always think back to that Steve Shorrock work of work as imagined and work as done, because I know that unfortunately I am incredibly arrogant as an anaesthetist, and I think I know the answer to everything. And usually before I even start an improvement project, I've got an idea about what might be the magic bullet that's going to make it better. But hopefully by going through these processes, doing some process maps, thinking carefully about what we're going to measure and how that's going to demonstrate an improvement in our processes or outcomes, I managed to rein myself back in from feeling like I've got all the answers and engage the whole team in the process of trying to understand what changes might make a difference. So brainstorming is a fantastic skill, and I'm sure a lot of you have used this in other realms of your life. But there's amazing research particularly from the business sector. There's some good work from Harvard Business School looking at brainstorming. And generally, the more people you have involved in a brainstorm, the wilder the ideas are, and the more ideas that you get, the more useful that brainstorming process will be in terms of coming up with novel ways to improve your system. It's definitely worth doing a Google search and seeing whether other teams around the country have managed to bring about some of the changes that you might be trying to do, and reaching out to them. It's amazing how generous people have been in improvement work that I've tried to bring to my NHS Trust in sharing what's worked in different places. And whilst it isn't always immediately transferable, things that have been successful elsewhere, there's often really good ideas to be taken and just tweaked to make them most appropriate for the system where I work. And then we've got driver diagrams and Pareto charts, and these are useful tools as well in improvement work. So driver diagrams are a little bit like process maps. Process maps and driver diagrams are both definitely tools that benefit from post-it notes being inherently involved in your life. And the idea of a driver diagram is it can help you to develop ideas and see how they directly link into trying to drive towards that outcome change that you're aiming to get to. And again, they're best developed with really wide input from as wide a multidisciplinary team as possible, to help them understand where the effort is going to be placed and help them understand why the change that they're being asked to make is contributing to a bigger piece of work in terms of changing the system. So a driver diagram is usually in 3 or 4 columns. The first column is your aim statement. So that is, we are going to reduce cardiac arrests in hospital wards by 50% in the next 18 months. And this is again why it's really important to get that right at the very beginning. And then we have our primary drivers and secondary drivers in 2 consecutive columns. So your primary drivers are improvement areas that you think that if you're going to get to your outcome place, you're going to have to address the improvement areas in your primary drivers. There's no way around that. And the secondary drivers are kind of specific key areas where you might plan specific changes or specific interventions to bring about the change in your primary drivers. So I'm going to share with you now the driver diagram that we had for that project, looking at reducing cardiac arrests in our hospital trust. So this was it. So we were trying to reduce, and we changed the wording actually. We were reducing CPR attempts in hospital wards by March 2019, and that was 18 months before that we set this aim statement. And our primary drivers, so this had come from us doing a lot of work in process mapping, in brainstorming, in involving the whole team in trying to understand what was happening to our patients and what was work as done, rather than what we imagined was happening to our patients who were having cardiac arrests in our hospital. And we came up with the notion that probably we needed to do a better job of understanding when patients were deteriorating. We were probably doing CPR on patients who didn't want us to be doing it, or maybe wouldn't have survived even if we had gone on to do CPR, and maybe we could give them a more dignified and controlled way of dying. And then we also felt that there was a huge opportunity for us to learn what was happening in our system, and that until we really made an effort to do that learning, it was going to be hard for us to get to our goal. And these were our secondary drivers. So in that primary area of our anticipatory care planning, we standardised how we communicated anticipatory care plans across our hospital wards, and we documented it in a much more robust and much more reliable way. And we thought that we could probably do something to help members of staff to have these hard conversations with patients and their relatives, and in a way that the staff felt supported to do that. And then you can see in terms of our primary driver around recognising patients that were deteriorating, we were rolling out a new national early warning score at the same time as undertaking this improvement project. So we took a huge amount of opportunity there to try and clearly document how patients should be escalated and build in a lot of education and learning around that. And we're still trying to examine whether there might be an electronic piece of software or some AI that might be able to help in the robustness of this step. And then you can see around learning from improvement, we really tried to find ways that we could feed back in real time to teams around events that were happening at work. And this then gave us these ideas as to ways that we could actually change our system to try and drive change towards achieving that 50% reduction in general wards. And there were loads and loads of things that we did, as you can see. So we did sim training. We got our palliative care teams, our specialist nurses involved in training doctors and nurses on hospital wards around holding end-of-life discussions. We created a structured ICU tool to try and understand when patients were deteriorating and it wasn't recognised what was going on, and we shared that as widely as possible. So this driver diagram helped us to change our outcome of our patients in a whole hospital trust. So this was 3 different acute hospitals across a huge geographical area, but it was the kind of the one document that really helped everybody to understand exactly what it was we were trying to achieve. And then we mentioned Pareto charts very quickly. So Pareto charts are a great way of helping teams to understand where they should put their effort in terms of trying to make a change. So this is an example of a Pareto chart for medication errors. So what we've done is here we've looked at every single medication error that's happened in our hospital, and we've categorized them according to the type of error, and you can see those along the bottom. So patients might have been given the wrong dose or an overdose, or they might have been given the drug by the wrong route, or there's been a technique error. And once we categorized all of those, we then put those types of drug errors in order of frequency. So the most common error that's made is that there's a dose that's missed, or it's then given at the wrong time and then it's the wrong drug. And then we can see that helps us delineate the difference between the vital few and the trivial many. If we want to change the number of medication errors that are happening in this hospital, there is absolutely no point us going to a huge amount of effort to eliminate people from delivering an unauthorized drug to the patient, because that's going to make that one medication error at the very, very far right of that chart is going to make a tiny, probably unmeasurable difference to our system. Actually, if we want to change our system, our effort is much more valuably placed trying to reduce the number of times when drug doses are missed for our patients. And then we get on to testing changes. So this is where that everyone gets to too quickly, because we always think we know the answer and we're all enthusiastic and we're engaged with our work and we want to make it better. But often what happens is we get to the idea of trying to implement something before we've taken the time to understand work is done. But once we've done all of that effort, once we've done some measuring of what our system is doing at the moment and understanding that we know that there's a difference between work as imagined and work as done, and we've drawn the process maps and we've come up with a big multidisciplinary diagram and we know what changes we want to test, then off you go. So a few key rules for quality improvement. I don't think you need permission to try something for 2 weeks. You might need permission to change something permanently, but if you try it for 2 weeks and it doesn't work and you measure it along the way and you can see it's not working, then change it back. That's completely fine. But measurement is the key. So is the change that you're making a difference, and is that change good or bad? And that's again when we come back to our balancing measures as being a really key component of improvement work. And then once we've tried it for 2 weeks and we've seen it's made a difference and we've established if that's good or bad, there's this really key step. So we adapt that change to make it even better. We adopt it as part of practice as normal, or if it's not doing what we want it to, we discard it and we move on to the next change. And the idea is that you have these continually rolling PDSA cycles where you plan a change, you implement it, you measure if it's making a difference, you adopt or discard it, and then you bring in the next one. And what you'll see over the course of hopefully weeks or maybe months is a change in your process measures, followed by a change in your outcome measure and an improvement that you've been trying to get to. So the science is simple. That's quality improvement, 3 questions and an ever rolling PDSA cycle. But hopefully I've given you some idea of how taking the time to understand work is done instead of work is imagined, taking the time to see what the process map really looks like on the shop floor rather than the 4 or 5 steps that you imagine, and using some of those tools like brainstorming or driver diagrams might hopefully help it be more successful along the way. And thank you so much.
Thank you very much, Catherine. We are fairly short on time for questions, so we'll stay on till 16:35 for those that can stay. There was a question from Amy Huckle. She's part of Leicestershire Partnership. How can we create a QI process map? Do we need particular program or software? So Lindsay's replied just to say that Vimeo works, but is there anything else that you would recommend?
I do. I've tried. There are software options out there. They're all rubbish. Use PowerPoint. Put it on a PowerPoint slide. You can change a PowerPoint slide to be an A4 document or an A3 document or even bigger, an A0 document. And on PowerPoint, the benefit is you can move the boxes exactly where you want to sit them. You can put text in exactly where you want it to be. So you can then display it in a way that's really easily and visually impactful. So PowerPoint is my top tip for process maps.
Thank you, Catherine. And the magic F11 button in Excel.
Yes.
Do.
The magic F11 button. So it doesn't work on my computer because unfortunately I'm speaking from a Mac. Otherwise I would share my screen and show you. But essentially, let's go back to that hand washing example. So you've got what you're examining people's hand washing compliance one day every week on consecutive weeks. So you've got weeks 1 to 26 on one column. And then in the column next to it, you've got a percentage of compliance. If you select all of that data and highlight it and then press F11, your Excel will just produce a run chart that won't have a median line on it. So then what you need to do is just select the data that is your compliance column. So if you select all of that and underneath it, you type equals sign, median in capital letters, and then in brackets, you select all of that column that you've got and press enter. That will calculate your median for you. And then if you go into the chart that Excel's produced by pressing F11, you can add a median line. If you right click and it says you can add a data line. So it really is very, very easy. And I'm more than happy to try and construct a little idiot's guide for that, if that would be helpful, and send it on. It's been something I've been meaning to do for years and I've just never gotten around to. So maybe this will be the motivation, if that would be a helpful thing for you.
I think that'd be great, Catherine. Thank you. And we can
Yeah,
put it
no
as
problem.
part of the resources for the general festival. So thank you. Is there anyone else who's got any questions? Feel free to put your hand up. That's fine. I'm just looking down the people's side as well as the chat. Nothing else in there. So Nick Hurton from LPT is just saying if there's anyone on the call who's interested specifically about QI LPT to get in touch. She's put the email address in there. Just one question from me then, Catherine, if I may. Sustainability with QI. So you do all this stuff and it's great and it all happens and you've measured it and you've made those changes. I think a lot of the time you have someone who's really passionate about something and they move on. How do you make that sustainable?
I think you win or lose the sustainability battle before you even start. So this is where this goes right back to the work is done and work is imagined piece. So when you really take the time at the beginning to understand work is done, the changes that you make almost universally make people's life easier rather than harder. So you've won the sustainability battle before you've even begin, because you're making improvements to the system that are actually easier for people to do than what their work is at the very beginning. If you're making people's work harder, it's never going to be sustainable once your change agents are lost. So I would say that piece of work that we did around improving cardiac arrest outcomes, we spent 3.5 years planning that improvement project before we even got to what our aim statement was going to be, because we spent such a long time trying to really understand what was happening to patients who were having cardiac arrest in our hospital. And on a much smaller scale, I did helped a trainee to do a nice improvement project looking at patients who were cancelled for operations because their warfarin levels were too high, so their blood was too thin and they couldn't then have their surgery as planned. And the key piece of work that we did in terms of making changes for looking after those patients was we phoned the GPs who were meant to follow instructions from our letters to explain what needed to happen with their warfarin in the run up to their surgery. And when we phoned the GPs were like, it's a nightmare. We don't understand anything. We never do this. It doesn't make any sense to us. And we get the letter 6 weeks after you've sent it, and then the patient's already had their operation. So that was then key to us understanding actually, how can we make this easier for everyone? So I would say you win or lose the sustainability battle before you even start. So don't bother getting all that enthusiasm wasted on making changes when you've not done the hard bit really to understand work is done.
Great advice. Thank you very much. Okay, if there are no more questions, I will close the session. I'm just looking, I think just lots of thank yous for you, Catherine, there. So thanks, everyone. Just a plug for the rest of this week. So the festival's going on until Saturday. So we've got 2 more kind of learning days, tomorrow and Friday, and then we've got the Family Fun Day on Saturday. There are 2 more QI sessions, so 1 tomorrow and 1 Friday. So if you've not signed up and you're interested, please have a look, go back to the Academy website and just have a look at the full schedule on there. I'll stay on for a few minutes. I know there was somebody that had a question about the wider festival, but other than that, thank you so much, Catherine, for your time. Thank you all for joining. And like I say, hope to see you at some of the other sessions this week. Thanks very much.
Hi, the question I was going to ask, can you hear me?
I can hear you.
Yeah. The question I was going to ask, because I work for Healthwatch Leicestershire. So we're just listening to this. I was thinking that's what we actually are looking into, like listening to public voices about what kind of changes they would like to see within the health and social care services. So by listening to you, I thought you're also looking into that kind of area. Is that right?
Is that a question for me? Or for you, Liz?
Anybody can answer.
Mm-hmm. I must admit, most of the improvement work I've done has been very, very secondary care based, just because that's my work environment. And we have done some really nice things around staff experience and staff engagement using improvement methodology, which I'm sure would be very translatable to improvement work. But you're absolutely right with a lot of the statements that you're making, that that anything that you think might benefit or where there's room to improve it, the best thing you can do is go out and get as 360-degree perspective on that thing as possible. So I think you kind of alluded to the idea of asking patients or relatives, as well as staff and clinicians and, you know, admin teams. And I mean, we involve porters and you know, the whole team in our improvement work when we do it. And I think definitely whenever you're trying to improve any kind of anything, the wider engagement you can get in trying to understand what that looks like to that portion of people that engage with it, the better.
That's true. I think often I get asked in the like, oh, you're doing. I think the service will change, because I think it takes so long time to get the services changed, and I think the public wants to see the result straight away. Because, for example, at the moment, what I'm hearing from lots of people, the GP and hospitals, the wait list, the A&E department, the wait list, and that kind of issues, you know. And I think what the public are feeling, that they're telling lots of people, but there's nothing been done. And I'm trying to say there will be done, but it takes time. The more you tell us and more we feed back to the service providers, eventually something will get well done, but everything takes time. So one of the things,
sorry, carry on.
One of the things I'm finding it difficult, I wanted to actually show them there have been some changes, you know, because when you do tell them to go onto the website, they said, oh, we haven't got time to do that. Can't you just tell us? But sometimes you do hesitate. Am I telling the right information, you know?
Yeah, I mean, I think I would encourage anybody to be very open and honest about, you know, when faced with that situation. And I appreciate it might be difficult, just in the same way that I've said that we have an idea of what we imagine our work to look like that doesn't necessarily correlate with what's going on the shop floor. The public are in exactly the same position. They've got their own perspective on what's happening, but they don't understand all of it. That's never the case. And I think there's nothing wrong in the honesty of saying we are really grateful for the information that you're giving us. That is part of the story, and that's really important for us understanding what's happening. But it's not the only perspective that we need to get if we're going to make changes that are meaningful and sustainable and long lasting. And that whole notion of involvement and engagement and being very transparent about what that looks like and sharing those you know, the outcomes of engagement with the whole team is a real key kind of pillar of successful quality improvement. So, you know, just like the run chart, I was meant to say to the wider team, a lot of our run charts are just on a whiteboard or like in the corridor. You know, it's very non-technical, and we just add the next data point on whenever it's been measured. You can do exactly the same thing in terms of sharing, you know, what we have learned from these focus groups or what we have learned from that brainstorming session is. So the whole process along the way, you're showing that you're doing something, but you're not trying to implement changes before you're ready to do that, because that is just a waste of everyone's time.
I think I'd just echo what you said there, Catherine, just about transparency and being honest with people. And I think it is really helpful to have good communications alongside any project that you're running. And also just to let you know locally, so we have been for quite a long time now trying to establish an LLR QI network. There is QI expertise throughout the system. So if there's anything that you need help with particularly, then please do get in touch with the Academy and we'll see how we can help you.
Okay, that's fantastic to know. Yeah. Okay. Thanks for sorry to take your time.
No worries.
Yeah,
I know there's still a few other people on the call. Are there more questions? No. Catherine, thank you so much. Really appreciate it.
Thank you very much. Both of you did a really great job. I'll see you Saturday. See you Saturday.
Take care.
Liz, I'll send a PDF copy of my slides over, and I might need a bit of time to construct that run charts guidance with Excel, but I'll try and put something together.
That'd be fantastic. Thank you. And I'll follow up with an email as well. And genuinely really appreciate you stepping in today. So thank you so much. Lovely to meet you.
Bye. Bye.
Take care. Bye.